Myocardial infarction, commonly known as a heart attack, is a serious medical condition. It occurs when blood flow to the heart muscle is blocked. This blockage prevents the heart from receiving the oxygen it needs. Without oxygen, heart muscle cells begin to die. This can lead to permanent damage to the heart. There are two main types of myocardial infarction, type 1 and type 2. Type 1 MI is the most common type. It is caused by a rupture of plaque buildup in the coronary arteries. This rupture forms a blood clot, blocking the artery and interrupting blood flow. Type 2 MI occurs when the heart's demand for oxygen exceeds the supply. This imbalance can be due to various factors. Some of these are coronary artery spasm, severe anemia, or low blood pressure. Understanding the difference between these types is crucial for effective treatment. Type 1 MI often requires immediate interventions to restore blood flow. Type 2 MI management focuses on addressing the underlying cause of the oxygen imbalance. Both types can have serious consequences. These consequences include heart failure, arrhythmias, and even death. It's important to remember that time is muscle when it comes to a heart attack. The sooner treatment begins, the better the chance of minimizing damage to the heart. Knowing the warning signs and seeking immediate medical attention can be life-saving. Diagnosing a myocardial infarction involves a combination of clinical evaluation and diagnostic tests. Doctors first assess the patient's symptoms. Common heart attack symptoms include chest pain, shortness of breath, and pain radiating to the arm or jaw. However, symptoms can vary, especially in women. Women may experience atypical symptoms like back pain, nausea, or fatigue. An electrocardiogram, or ECG, is a crucial tool in diagnosing a heart attack. It records the heart's electrical activity and can reveal abnormalities indicating heart muscle damage. Elevated cardiac biomarkers, specific proteins released into the bloodstream after heart muscle injury, also aid in diagnosis. Blood tests detect these biomarkers, confirming the occurrence of a heart attack. Cardiac catheterization provides a definitive diagnosis and guides treatment decisions. This minimally invasive procedure involves threading a thin tube through a blood vessel to the heart. It allows visualization of the coronary arteries, identifying blockages, and assessing the extent of damage. Treating a myocardial infarction typically involves a multi-pronged approach. The first line of treatment often includes medications to prevent further blood clotting, reduce the heart's workload, and manage symptoms. Aspirin, an antiplatelet agent, helps prevent clot formation. Nitroglycerin relaxes blood vessels, improving blood flow. Morphine is often administered for pain relief. Traditionally, beta blockers have been a cornerstone of post-heart attack treatment. These medications slow the heart rate and reduce blood pressure, decreasing the heart's workload and oxygen demand. However, recent research, such as the REDUCE AMI trial, challenges the long-held belief in the universal benefit of long-term beta blocker use after a heart attack. The study suggests that in patients with preserved ejection fraction, a measure of the heart's pumping ability, long-term beta blockers may not reduce the risk of death or subsequent heart attacks. This finding has significant implications for treatment protocols, emphasizing the need for personalized medicine and ongoing research to optimize treatment strategies. In addition to medication, procedures like angioplasty and stenting can restore blood flow to the heart muscle. Angioplasty involves inserting a balloon-tipped catheter into the blocked artery. Inflating the balloon compresses the plaque, widening the artery. Stenting often accompanies angioplasty. A stent, a small expandable tube, is placed in the artery to keep it open and maintain blood flow. Myocardial infarction with non-obstructive coronary arteries, or MINOCA, presents a diagnostic and therapeutic challenge. In MINOCA, patients experience a heart attack despite having no significant blockages in their coronary arteries. This condition accounts for a significant proportion of heart attacks, particularly in women. Women are 5 times more likely to experience MINOCA than men. This disparity highlights the importance of considering sex-specific differences in heart attack presentation and diagnosis. MINOCA is often misdiagnosed or underdiagnosed, leading to delays in treatment and potentially worse outcomes. The exact causes of MINOCA are complex and not fully understood. Potential contributing factors include spontaneous coronary artery dissection, coronary artery spasm, and microvascular dysfunction. Diagnosing MINOCA requires a high index of suspicion and specialized testing. Cardiac MRI and intracoronary imaging can help identify abnormalities not visible with traditional angiography. The significance of Myocardial lies in its potential long-term consequences. Despite having normal coronary arteries, Myocardial patients remain at risk for future cardiovascular events. Recognizing Myocardial as a distinct entity and developing targeted treatment strategies are crucial to improve outcomes for these patients.